It's already 2 o'clock. We'll start. Welcome all. Please mute yourself, but always show your video picture. Sign in your name. Your Facebook account and your email address in the chat box. Please include names of the companions attending. Use the chat box to ask questions and make comments while the pep talk is on. There'll be group pictures at the start and end of the pep talk, so please show your face in the video. As a reminder, please take the online CUM evaluation test exercise or ULETE for mastery of learning and have a certificate after you get a perfect score. The link, I placed the link in the Viber group as well as in the Facebook group. I will ask Abed to place the link in the chat box. Also, as a reminder, 50 ULETE certificates will entitle 1 mentees to a free voucher for telemedical consultation, like this. Let's now have a group picture taking before we start in 2 minutes the lecture proper. Please turn on your video. Please show your face. Okay. One, two, 1, 2, 1, 2, 3. Okay. Yes. I have a patient empowerment program in which I like to empower the lay people or patients to take control in the management of their health. There are 3 courses in the PEP Talk. I completed the core course on October 9, 2021. From October 23, 2021 onwards, I have been tackling health disorder and health issue courses. This may take 3 years or longer. My pep talk today is entitled Fundamentals and Generalities in Medical Management of GOITER, Part 2. This is part of the health disorder course. The empowerment objective is for the lay people to have an understanding of the fundamentals and generalities of the medical management of GOITER. In Part 1, which was taken up last week, we discussed what is a GOITER, common types, causes, and how common are the goiters. We're now in Part 2, in which we will tackle clinical diagnosis of goiter and paraclinical diagnostic procedures for goiters. Part 3, which will be done next week, will be on treatment of goiters and health restoration and maintenance after treatment for goiters. Definition of terms in the title and the limitation of coverage of my talk. Fundamentals to mean simplest and essential facts and theories which can serve as a basis or foundation and support for advanced information. Generalities to mean general statements of information, not covering specifics and details. And medical management to mean diagnosis and treatment usually done by physicians. Let's start with the clinical diagnosis of goiter. When you say clinical diagnosis, it means a conclusion or a decision made by a physician after examining a patient and after evaluation of the data on symptoms and signs. There are 2 kinds of data that the physician evaluates. The first is the symptom data, and these are what are felt and observed by the patient or a person on his or her body. And signs are the findings of a physician after doing a physical examination of the patient. Procedures in the clinical diagnosis of goiter, patients presenting with symptoms, and then the physician evaluates the symptoms to look for cues for a goiter, and then cues or a pattern for a particular goiter disease. Then he does physical examination to look for sign cues for a goiter and also cues or pattern for a particular goiter disease. After which, after getting the sign and symptom data, the physician processes this to determine whether a goiter is present, and if present, what is the particular goiter disease. And the processes used in the clinical diagnosis of goiter, you have the pattern recognition and the prevalence. Pattern recognition process means realization that the patient's presentation conforms to a previously learned picture or pattern of a disease. Whereas prevalence process means the choice of a diagnosis is based on the frequency of occurrence of the disease in a certain locality, in a certain age group and sex group, and in the affected organ and system. Common symptoms that will lead to suspected presence of goiter are the following. These are the more common ones. Lumps on the front, base, and central part of the neck, which moves up with and down, ups and down with swallowing, okay? Or lump or lumps on the side of the neck, and palpitation, sudden weight loss, persistent fatigue. So these are the more common signs. So in the presence of persistent fatigue, one will be alerted on the possible hypothyroidism. So persistent fatigue is a common cue or alert signal for hypothyroidism. There are a lot of symptoms of hypothyroidism, but which are very, very non-specific. In the presence of palpitation and sudden weight loss, one has to think of possible hyperthyroidism. Again, there are other symptoms of hyperthyroidism, but these are the more common ones. In the presence of lumps on the neck, in the front, base, and central part, which moves up and down with swallowing, and then if there is also a lump on the side of the neck, okay, these are cues or alert signals for tumors because of the lump presentation, which could be benign or malignant. Okay? Whatever it is, it has to be evaluated further, and it needs more sign cues. I will present my way of evaluation. As we know, there are a lot of different ways of evaluating patients with goiter by a lot of physicians. Okay? My approach is that after a patient tells me her or his symptoms, which may suggest a goiter, I examine right away the neck and check the pulse rate. This is the minimum. Then I additionally gather other data as indicated with the goal of coming out with a more specific and accurate clinical diagnosis. Scenario 1, after examining the neck and checking the pulse rate and gathering other data, okay, this is one first scenario. Supposing the thyroid gland is not palpable, not enlarged, there are no nodules in the thyroid gland, no neck nodes on the side of the neck, the pulse rate is less than 90 per minute, which is considered normal, and then there are no symptom cues for hyperthyroidism and hypothyroidism. The clinical diagnosis will be the thyroid is normal thyroid gland. Another scenario, another situation, the thyroid gland is palpable, it's enlarged, and there are nodules on the thyroid gland. The clinical diagnosis now is there is a goiter, but as to which type, it has to be evaluated further to come out with for a more specific diagnosis as to the type. Another situation, there is a goiter, meaning that there's enlargement, there are nodules on the thyroid gland, but if the pulse rate is less than 90 per minute, then the diagnosis is a non-toxic goiter. Non-toxic means there's no hyperthyroidism. It could either be normal uh, level of thyroid hormones or hypothyroidism. Now, the other scenario is that there is a goiter, but the pulse rate is equal or more than 90 per minute. Then the clinical diagnosis is a toxic goiter because of the possibility of hyperthyroidism. Toxic implies hyperthyroidism. To repeat, there is a goiter, another situation. The thyroid is diffusely enlarged. The pulse rate is equal to or more than 90 per minute, which suggests toxicity, toxic goiter. There are tremors, and then sometimes the patients can present with bulging eyes. Okay. So the clinical diagnosis is toxic goiter, specifically hyperthyroidism. If there is concomitant bulging eyeballs, then the specific type of hyperthyroidism is the so-called Graves' disease. There are some patients who will not present with bulging eyeballs, so the diagnosis would just simply be called hyperthyroidism or toxic goiter. Another scenario, there is a goiter. The thyroid gland is diffusely enlarged. The pulse rate is less than 90 per minute, which is normal, but there is persistent fatigue. So the diagnosis is non-toxic goiter, and the opposite of hypertoxic is hypothyroidism. Another scenario, there is a goiter. The thyroid is diffusely enlarged. The pulse rate is less than 90 per minute. There is adequate intake of iodine-rich foods in the history. There is no history of persistent fatigue. So the diagnosis will be non-toxic goiter. Specifically, the most common one based on prevalence is a diffuse colloid adenomatous goiter. Same situation, but this time there is history of inadequate intake of iodine-rich food. So this time, the clinical diagnosis is non-toxic goiter, and more specifically, this is due to iodine deficiency, or the specific diagnosis is iodine deficiency goiter. Another situation, there is a goiter, there are nodules, there is or are nodules, the pulse rate is less than 90 per minute. Okay. This time we call it non-toxic nodular goiter. Okay. Which has to be further evaluated for more specific diagnosis because there is a nodule, there are nodules, we have to determine whether it's cancer or not. There is a goiter. The thyroid gland has nodule or nodules, single or multiple. The pulse rate is less than 90. So it's nodular, non-toxic goiter, whether it's cancer or not. Okay, but in the concomitant presence of cues for malignancy, like the nodules are hard, they're fixed, they're not moving sideways or upwards, and then there is concomitant hoarseness of voice, and there might be neck nodes on the side of the neck, and then a distant mass, a mass outside the neck, okay? In which case we suspect thyroid cancer. Okay? Again, there's about 4 types of thyroid cancer which has to be differentiated. In this particular patient, the cues for cancer is a hard nodule, fixed, hoarseness of voice, and neck nodes. So this is a cue for papillary thyroid cancer, a specific type of thyroid cancer. Another patient, the positive cue for malignancy here is a distant mass. You see the mass on the scalp, okay, which is suspicious for metastasis. So this time, the diagnosis is follicular cancer. Another situation, probably this is the last. There is a goiter. There are nodules. Okay. The pulse rate is less than 90. So less than 90 is non-toxic. So with nodules, nodular goiter. So it should be non-toxic nodular goiter. As to the specific type, if there are no cues for malignancy, like hard nodules, fixed, hoarseness, neck nodes, and distant mass, then based on prevalence, based on common occurrence, remember our processes that we use for clinical diagnosis is pattern recognition and prevalence. So based on prevalence, it's benign colloid adenomatous goiter. So this is my disclosure. I've been using the ROJoson way of evaluation for more than 40 years now. I can honestly say my batting average is more than 95% accuracy in clinical diagnosis, even without laboratory test. And the less than 5% error, I corrected it right away with paraclinical diagnostic procedure so that I can make it 100% accurate in the end. So let's now go to paraclinical diagnostic procedures for goiters. The foremost indication for a paraclinical diagnostic procedure can be stated this way. If you are not certain on the primary clinical diagnosis and you need to be certain or be more certain before treatment, then go for a paraclinical diagnostic procedure. To decide on the indication of the paraclinical diagnostic procedure, the physician uses two processes. One is the degree of certainty on the primary, the first clinical diagnosis, and comparison of the treatment plans for the primary and secondary clinical diagnosis. And as a rule, there is no need for paraclinical diagnostic procedure if one, you are quite certain of your primary clinical diagnosis, and the treatment plans for the primary and secondary diagnosis are the same. If there is a need for a paraclinical diagnostic procedure, the physician uses the BRCA process. Okay. B stands for benefit, R, risk, C, cost, A, availability. So he has to have a tabulation of a table that shows this tabulation. The first column, options, then second column, benefit, then third, risk, then cost and availability. Then the physician, as I said, using this table, lists down the various options and gives the data on the BRCA. And then once the data are given, the patients usually ask what he or she prefers first before the doctors will give the final recommendation. Example of BRCA comparative analysis. Okay, so you have options 1, 2, 3 in column 1. And then in terms of benefit, so we're talking about paraclinical diagnostic procedure. Benefit will be in terms of which one will give you more information as to the diagnosis. Okay. So for option 1, the accuracy of the test is 99%, an example. Option 2, 90%. And option 3, only 60%. Supposing that all the risk in the 3 options are acceptable. But in terms of cost, there are differences, 4,000 for option 1, 3,000 for option 2, and 1,000 for option 3. Assuming that they are all available, so what will be the recommended option? So if you look at the put priority on the benefit, which is the goal, 99% accuracy, you would choose option 1, which costs 4,000. If the patient cannot afford 4,000, he can only afford 3,000, then you can go for the second best, not the 90%. But do not go for the third option. 60% is no good, okay? Even though the price is only 1,000. Common instrumental and laboratory diagnostic procedures that can be used after clinical diagnosis of goiter include the following: thyroid function tests such as FT3, FT4, TSH, Imaging procedures like ultrasound, thyroid scan, CT scan, MRI, PET scan. These are just examples. Needle aspiration with or without biopsy. It has to be said that the competencies required of physician managing goiter should have the following, should consist of the following. So the physician should know the uses and indications of all known diagnostic procedures for goiter. He used one or two as needed and as indicated. Select the most cost-effective one and know how to interpret the results. So these are the competencies required of physicians managing goiters. For thyroid function tests like FT3, FT4, sometimes it's just T3, T4, TSH. These are used to check the level of thyroid hormones in the blood. If it's normal, you call it euthyroid. If it's abnormal and elevated T4, at least T4, T3, and the TSH is not elevated, we call it, we diagnose it as hyperthyroid. Hypothyroid means the thyroid hormones is below the normal level. So indications for the thyroid function test. One, when the physician is not sure whether a patient has hyperthyroid or hypothyroid even after the clinical examination. And number two, when they are needed to have a baseline and follow-up values to monitor subsequent medical treatment. Supposing the patient will undergo medical treatment and then follow-up will include getting the values of the thyroid hormone levels, then the test will have to be done. Interpretations of the thyroid function test. Euthyroidism means normal. So you have normal FT4 and normal TSH values. It's hyperthyroidism if you have elevated T4, FT4, and below normal TSH. And hypothyroidism if the FT4 value is below normal but there is an elevation of the TSH. This is the general guidelines in the interpretation of the thyroid function test in terms of which one is present, hyper, hypo, or even euthyroidism. For imaging procedures, the indication is when they are needed to evaluate the structure, the anatomy, okay? Examples will be ultrasound, CT scan, and MRI. And at times, if the function needs to be evaluated, one can use the thyroid scan and the PET scan, okay? So with the various options available, the physicians will have to choose the most cost-effective ones. Indications for ultrasound, CT scan, and MRI. As I said, this can be used to evaluate the structure, the size of the thyroid gland, whether a nodule is present, and if it's present, whether it's benign or malignant. The imaging procedures can also be used to evaluate the function. Examples would be the thyroid scan, okay, which uses a radioactive isotope injected into the patient's bloodstream. And this is used primarily to determine whether a nodule is hyperfunctioning or not. So you can see that on the corner of the slides, you have the hot. It's a black, extremely black, so it's a hot nodule. So it means this nodule is secreting a lot of thyroid hormones. Okay? So it's called hyperthyroidism. It might be causing hyperthyroidism. In contrast to this one, which does not have any uptake, so this is what is called a cold nodule. Needle aspiration biopsy, with or without biopsy, indications when there is a need to determine whether a nodule, so the starting point would be the presence of nodule, whether the nodule is solid or cystic, okay? And if cystic, after doing the needle aspiration, if the mass, the nodule completely disappears, then it becomes a therapeutic in purpose. It started with diagnostic purpose, and then, but since the cyst has been reduced in size, the needle aspiration is now considered a treatment, the type of treatment. Okay. So the other indications for needle aspiration is that when there is a need to get a sample of, we usually get a sample of the solid, if it's solid, okay, for biopsy to check whether benign or malignant cells are present or not. So this particular glass slide shows the sample of tissues gotten from the solid nodules of the thyroid, which will be submitted to the pathologist for microscopic examination. When you say microscopic examination, this is what we call biopsy. So this just shows you the how a needle aspiration is being done. Patients sitting in the clinic. This small hypodermic needle and syringe is used to aspirate. So in this particular patient, the nodule turned out to be cystic. That's why you can see the fluid coming out. The fluid is usually called colloid fluid in thyroid. That's why all you still remember the names that I always use: colloid adenomatous nodule, colloid adenomatous goiter. So the colloid part in the title, in the name, is the fluid part. No? Okay, so you have more fluid coming out now. Okay, so this is colloid cyst. Let me repeat the competencies required of the physicians. They must know the uses and indications of all the known diagnostic procedures. They must know how to only use them as needed and indicated, select the most cost-effective one, and know how to interpret the results. There are several issues to discuss in the use of paraclinical diagnostic procedure, as there are a lot of confusions, not to say errors in happening. Okay, number one, this is usually done, committed by the physicians. Okay. Ordering tests not needed for diagnosis of goiter. Shotgun approach, ordering every possible test just to catch a specific diagnosis of goiter, not relying much on the clinical diagnosis. Inaccurate results is another issue, not knowing how to interpret the results. And then the other one, the last issue, will be using FAD, the most common one, the trend, without comparative analysis, benefit, risk, cost, availability of other options. So usually, if they just use the FAD, there's no consideration for the cost effectiveness and patient's preference. This is a rampant practice which are not recommended. Ordering thyroid function tests and thyroid ultrasound in one go. Okay, FT3, FT4, TSAs, and thyroid ultrasound in one go, in one package for all patients with goiter. This is a rampant practice. So this is an example of a shotgun approach, and patients with nodules with no symptoms of hyperthyroidism or hypothyroidism do not need to have thyroid function tests. A lot of times you can diagnose hyperthyroidism and hypothyroidism just based on the signs and symptoms. Okay. A lot of times physicians accept results as final. Again, this is a common practice and this has to be remedied. Okay. But one has to remember that results of paraclinical diagnostic procedures are not always 100% accurate or perfect. There are errors, and also non-conclusive. Okay, non-conclusive means not definite. Okay, which must be recognized by the physicians. The physicians must know how to interpret and evaluate the results and then correlate or check it with the findings on the patient's body, okay, the signs and symptoms, and decide whether to accept or to hold or to repeat. So these are the three decisions that the physicians will have to make after evaluating interpreting the results of the paraclinical diagnostic procedure and correlating it with the clinical findings. So the other issues, as I said, using FAD, okay, the most popular ones without consideration of the table that shows benefit, risk, cost, availability. So examples of BRCA, okay, for thyroid, these are imaging procedures commonly done for thyroid. So you have the ultrasound, thyroid scan, CT scan. Okay. So if we try to analyze the different options, okay, these are all indirect examination because it's imaging. But in terms of benefit, okay, so you have 2 plus for ultrasound, 1 plus for thyroid scan, and then CT scan 3 plus. Okay. Then no pain for ultrasound, no pain also for thyroid scan, but there is radiation. No pain for CT scan, but radiation. And in terms of prices, the CT scan is the most expensive. Okay. So if you were to choose which one is the most cost-effective procedure in this imaging procedures, okay, then you would choose ultrasound as the first choice. Another example, this time putting in biopsy. Biopsy is also a paraclinical diagnostic procedure. Comparing biopsy and the ultrasound, thyroid scan, CT scan, biopsy will give you the direct information because you get a sample from the tumor itself. So the diagnostic yield will be the greatest, 4 plus. Okay. But the only problem is that there is a pain, usually minimal. Okay. Okay. The cost is here, comparative. Okay. So if you were to choose which one, the patient is not afraid of the pain, can accept pain, then you choose biopsy. Okay. So summary and takeaway, I have discussed the following topics: clinical diagnosis of goiter and paraclinical diagnostic procedures for goiters. Takeaway in relation to patient empowerment: be always in touch with reliable medical information on fundamentals and generalities in medical management of goiter. Knowledge is power. It gives power. Use the 4 Ks of patient empowerment, which are kaalaman, kakayanan, karapatan, and kapangyarihan to gain greater control over decisions in the medical management of goiter. So with that, I end my pep talk today. Fundamentals and Generalities in Medical Management of Goiter, Part 2. I hope I have empowered you to have a better understanding of the fundamentals and generalities of medical management of Goiter, Part 2, which are clinical diagnosis and paraclinical diagnostic procedure. So before we go to the question and answer portion, as a reminder, please take the OLETE for Mastery of Learning and have a perfect score to get this certificate. And then 50 OLETE certificates entitled one to a voucher. Okay, entitled one to a free voucher. We are now on our 34 or 33, 34th lecture. Okay, so there are already 34 OLETE certificates are being given away. Okay. So let's now have a group picture taking before we start the QA or interactions. Okay. Okay. Christy, would you like to show your face? Belet? Okay. One. Okay. Belet. Oh, last one. Christy. Okay. We're now complete. One, two. Oh, baby. Wala si baby. One, 2. Okay. Okay, so the floor is now open for questions, comments, interactions, suggestions. Okay. Okay. Last time, it was just an intro on the type and the prevalence. This time, it's more direct to the point. More, I think, you will learn a lot from today's lecture. Okay, because I've given you a lot of scenarios which you can identify if you have one. Okay. Okay. So any questions? Who likes to share their experience also? Nobody? Any question in the chat box?
Wala, Doc. Walang question.
Walang questions. Okay.
Doc, tatanong ko lang. Parang napansin ko lang, parang mas marami yatang mga babae ang nagkaka-goiter. Meron kaysa mga lalaki.
Tama.
Meron ho bang medical or medical explanation or scientific explanation? Parang mga kakilala ko ho, mga babae halos may goiter. Wala pa akong na-engkwentrong lalaki na nagka-goiter.
No, okay. Actually, walang specific explanation being promoted in the internet, in the literature. Okay, but I can try to surmise, try to guess. Even halintulad natin sa breast, di ba? Sa breast, mas common sa babae, meron din sa lalaki, di ba? Okay. You can have breast cancer sa lalaki, no? It's most likely because of the hormonal level ng babae, no? Okay. Sa lalaki, konti lang estrogen, no? Okay. Sa babae, marami, no? Sa sa thyroid naman, I can, okay, probably, ito, guess ko lang ito, ha? Okay. Considering ang pinaka-common is colloid adenomatous goiter. Ang pinaka-common, 90%, no? Okay. At 90%, and the rest, kung thyroid cancer tsaka the others, halos equal ang ano, no? Equal ang distribution. Thyroid cancer, pero may nagsasabi ng ano in the literature, pag lalaki, mas mataas ang incidence ng thyroid cancer, no? Okay, ganon, no? So, to which I don't really subscribe. Sa akin, it all depends on the on the examination, no? Pero dun sa, kasi majority, 90% of thyroid goiters are benign colloid adenomatous goiter. At the moment, wala na tayong iodine deficiency goiter. Kung meron pang iodine deficiency, probably equal ang distribution. Kasi lalaki, babae, tatamaan, no? Okay. But at the moment, the more common is the colloid adenomatous goiter, in which nobody can really tell us what is the exact cause, no? It's not cancer. It's not cancer, no? Benign colloid adenomatous goiter. From my experience, it's probably due to the yung mga, what do you call that? Yung mga nangyayari sa katawan ng isang babae, which is actually a lot of things, mabigat, di ba, compared to lalaki, no? In terms of hormonal changes, no? Okay. So, yeah, pregnancy. Kung pag may pregnancy ka, no? Pag pregnant ka, lumalaki yung thyroid mo, no? Okay. Ganon. So, sa lalaki, walang pregnancy. Kaya yung thyroid, hindi na napapwersa. Di ba? Okay. And then, I think, baka, I don't know whether stress. Baka mas marami kayong stress, I don't know. Okay. So, but, yun, no? Because of the proportion of colloid adenomatous goiter because of the may female factor that can cause it. No? Kaya sinasabi ng mas common yung goiter sa babae. Na? Okay.
Okay po. Thank you, Doc. Thank you.
These are established statistics talaga, na based on what are published. No? Pero for a particular patient, no, you cannot use the statistics to make a diagnosis. No? Pag sabihin, kasi a lot of times yung isang common pitfall, sabihin, lalo na sa lalaki, sabihin, ay lalaki ka, may bukol ka, kaya baka cancer yan. No? Okay? Hindi tama yun. No? So you have to look at the characteristics. Ibig sabihin, if it's fixed, is it movable? No? Is it kung may neck nodes? Okay? So yung process na binanggit ko kanina, na? Okay? By elimination, kung wala, benign pa rin. Pwedeng benign. Na? Okay.
Okay. Thank you po. Thank you, Doc.
Any questions? May we get,
is it true na pag daw yung ang isang babae nagbuntis at tapos umire, nagkakaroon ng goiter?
not because of the ire. Not because of the ire per se. No? Baka, ang sinabi ko nga, baka may hormonal factor no? Parang very stressful sa katawan ninyo. No? Okay. Kasi pag let's say, pag at puberty, makikita ninyo, may lumalaki rin ng goiter. Yan yung tinatawag na physiologic. No? Okay. At puberty, lumalaki yung leeg. No? Because of the stress of the hormonal load. No? Ganon. So pregnancy, ganon din. Di ba? Pregnancy, meron kayong maraming hormones na going around, working in your body. Kaya tumataas yung incidence ng mga bukol-bukol. But these are usually mga benign colloid adenomatous goiter. No? Okay. So hindi iri per se. Hindi iri per se. It's a long-term one. No?
Doc, may question sa chat box from Chris N. Hello, Doc. Ang whole body bone imaging po ba nakikita kung may nodule ka or bukol sa thyroid or sa neck?
Whole body imaging, which is what? Whole body thyroid scan? Anong specific?
Whole body bone imaging po.
Bone? Whole body?
Opo. Ang tanong niya, ang whole body bone imaging po ba nakikita kung may nodule ka o bukol sa thyroid or neck?
Kung bone scan ang tinatanong mo, hindi. Kasi the bone scan is for the bone. For the bone lang yon, specific for the bone. So hindi usually hindi siya lalabas dun sa sa thyroid, no? Ang bone scan, ginagamit niya isang radioisotope, yung dye, no? Radioactive iodine dye, which is not easily take up by the thyroid gland. Okay? Yung thyroid scan, there's a name there, thyroid scan, they use a specific radioisotope which is called radioactive iodine. No? Radioactive iodine. Yung sa bone scan, I think they use galenium, something, other types. No? So yung pag ginamit mo yung iodine, radioactive iodine, ito take up ng thyroid. Kaya yung radioactive iodine scan is will detect yung thyroid. That's being used for evaluating the thyroid gland. Kanina yung pinakita ko, hot or cold nodule, yun, no? So uptake by the thyroid gland on the iodine, no? Okay.
Another question po from Aida Antonio. Aida Antonio. Doc, how about po yung children's dwarfism or Down syndrome? Related po talaga sa nanay na may goiter problem?
Mahirap sabihin. May contribution, might be, pero bihira.
Dwarfism po, Doc.
Ha? Ha?
Dwarfism. Nawala yung SM.
Yeah, nakita ko. Dwarfism yung duwende. Parang duwende, maliit. Di ba?
O kaya po yung maliit ang katawan lang. So parang mga stunted growth.
Yeah, theoretically it's possible, no? Kasi baka hypothyroid yung nanay, no? And then but magiging hypothyroid yung bata during the pregnancy, di ba? Ganon. Okay. But nowadays,
Lalo na po yung mga nanay na late mga anak, mga around 40s na nanganak, tapos ganun naging anak, may Down syndrome.
dalawang bagay yun. Yung down, halos walang kinalaman kung Down syndrome.
Okay.
No? Kung dwarfism, baka pwede pa. Diba? Kasi baka kulang yung the mother is in hypothyroid, kulang, no? Okay. Tapos syempre hindi nakukuha ng anak yung iodine from the mother, no? Okay. So but nowadays halos wala na tayong iodine deficiency goiter, no? Kasi mga pagkain natin dami na may iodine.
Yung salt with iodine. Iodized salt.
Iodized salt, no? Okay. So halos wala na. It's due to other causes na, no? Okay. Okay.
Thank you for that.
Okay. Any more?
There is a question pumasok sa messenger ko from Baby Espiritu. Pag may thyroid heart, din ba sa nagbabara yung kinakain dahil sa thyroid?
Depende sa laki. Number 2, depende do kung cancer or not, kasi cancer can infiltrate, can invade the esophagus, yung daanan. Okay? Then depende dun sa size pa rin. Okay? Okay. Kasi you can have, kung benign ang bukol at malaking-malaki, iipitin niyo yung esophagus, no? Kung maliit lang, hindi, no? And then kahit na benign pwedeng mangyari 'yon. Pero usually hindi gaano ka serious yung bara, no? Pero kung cancer 'yon, talagang in-invade na, talagang kinain niya yung esophagus, 'yon, talagang seryoso yung barado, no? Ganon. Any more? May link, may question. Kanina may nakita ko yung link. Ano pang questions? May question si Deli?
Yeah. Doc, how will we know we have goiter? If there is no sign, buccal, or any symptoms, do you have to check T3, T4, and TSH?
Yung sinabi ko nga, how will you know we have goiter? Number 1, ang unang slides ko kanina, if the thyroid gland is not enlarged, no, hindi siya palpable, walang buccal, and then the pulse rate is less than 90 per minute, no, walang mga bukol-bukol, no symptoms of hypothyroidism, walang symptoms, then normal siya. Okay? So you don't, 99% normal. So you don't need to have yung mga thyroid function test, na? Okay? So kadalasan ino-order ng mga doktor yan, na? Okay, na hindi kailangan, na? Kasi basta gusto ng pasyente, gusto nang malaman, ikuha ng test, no? Pero usually sinasabi ko sa mga pasyente, pag in-examine kita, wala ka ng symptoms, 99% wala ka, no? Okay. So, but if there are symptoms na may bukol, no? Okay. Then, as I said, kung yung bukol ay ang pinag-usapan, cancer o hindi. So, you don't need your T3, T4. Yung T3, T4 is for function test, no? Ngayon, kung diffuse, yung malaki, yung buong gland is malaki, then and then yung pulse rate mo is more than 90 per minute, no? Then you have to suspect hyperthyroidism, no? Hyperthyroidism, in which case you have to take yung T3, T4, and TSH, no? Okay. So may mga indications, no? Okay. So okay. Any more questions? Ano, may questions. I bet merong si Mel, paki-post nga yung ano daw. Palete, link.
I did na. Kanina pa.
Okay. I-post mo lang ulit, baka late siya pumasok. Kung late, hindi makukuha eh. No?
Okay.
So, may question si Chris yata, no? Sa mga tulad po namin na under surveillance po, anong test ang pwede namin include para early detection? Anong under surveillance for what? For breast cancer, for thyroid cancer? Chris? Sesha? Okay. Kung breast cancer surveillance, if you're not if you don't have any symptoms of thyroid, goiter, no need. No need. No? Okay. Wala namang direct association. Pag sinabi may breast cancer ka, siguradong meron kang thyroid. Bihira yun. No? Okay. Bihira. 1% lang. No? Okay. Now, if you have symptoms of goiter, then that's the time you do some tests already. Okay. So any more questions? Next week, we will be discussing treatment. No? Okay. So, maraming issues that are involved in the treatment. No? At probably I can allay some of your fear kasi I think some of you here, present here, merong mga goiter, di ba? But MCAG yon, no? MCAG, multiple colloid adenomatous goiter, no? Which do not need to be worried about. Huwag kayo matakot, no? Okay. Si Aida is a thyroid cancer, kaya lang, ang ganda ni Aida, 33 years na, walang problema. No? Okay, so no need to worry. No? Okay. Okay. So any other questions? We still have 3 minutes to go. T3, T4.
I just, one question lang po. Kasi yung, remember our driver, he's so afraid to have surgery. So the options are surgery or radioactivity. Yung which would you recommend more, surgery or radioactivity?
There are 3 options which I will discuss also next week. No?
Next week. Oh, sige.
3 options. Okay lang. Sasagutin ko kasi okay lang yung mga gano'n. 3 options for patients with hyperthyroidism. No? You have medicine. No? Yung I think gano'n iniinom na niya ngayon. No? Yung Tapasol, yung PTU, no? Metimazole, Tidine. No?
Tapdin.
Tapdine. No? Okay, that Tapdine belongs to that category of medical therapy. Then the other option is radioactive iodine therapy. No? The other radioactive yung ini-inject dun sa bloodstream and then it will go to the thyroid gland. Doon siya mag-concentrate and then.
But that's expensive, no?
A little expensive, yeah. Okay. So and then iba-burn niya yung thyroid gland para hindi siya mag-produce ng excess thyroid hormones. Kasi hyperthyroidism means it's producing a lot of thyroid hormones. No? Iba-burn niya. No? Okay? So ang downside niyan, ang downside niyan is that eventually magiging hypothyroid naman siya kasi tuloy-tuloy yung effect ng radioactive iodine eh, no? Mga usually forever yan, tuloy-tuloy. So susunog sa initially baka konti lang masusunog, no, na thyroid gland, no? Kaya magiging normal, no, yung thyroid level niya, hormones level, but eventually magiging hypothyroid siya, no? That's the downside, no? Okay? But the upside there, walang operasyon, di ba? Okay? Pero the other downside is the cost, di ba? Okay. Now, yung surgery naman is tatapisin lang naman eh. Yung the other option is surgery, tatapisin yung thyroid gland, no? Papaliitin, ang matitira, let's say 1 or 2 grams, no, of thyroid gland, which will produce just the right amount of thyroid hormones, no? So yan ang rationale for the surgery, no? Okay? So wala nang radioactive iodine, no? Okay? But ang downside naman yan is may operasyon, and then meron kang mga possible complications from the operation, like bihira naman the infection, bihira naman yung bleeding, no? Saka yung hoarseness of voice, baka tamaan yung yung nerve, no? Ganon, no? Okay. But again, kahit na kumisan kasi yung tansyahan lang naman yung yung tansyahan lang yung tapyas sa surgery, di ba? Okay? We don't really know which exact amount will produce the right amount of thyroid hormones, no? So itatapyas lang, konti-konti lang, no? So sometimes it might recur also, no, babalik yung hyperthyroid niya, okay? Or baka sumobrang tanggal naman, baka lumiit, gusto, baka maging kulang naman sa thyroid hormones, no? So, but in the end, okay, probably the best way to decide here is how big is the goiter, no? Okay. Kung maliit lang, meron pa siyang option for medicine, no? Okay. Kasi kung malaking-malaki na, kahit na mag-medicine ka, kahit na mag-radioactive iodine ka, hindi siya liliit. Makokontrol lang yung level of thyroid hormones. Yun lang makokontrol, no? Pero yung size itself, kung malaking-malaki na, bulging, kitang-kita, no? So, operation ang the better choice, no? Gano'ng kalaki na ba, Chuchi?
Maliit pa ho eh. In fact, hardly noticeable because hindi pa masyado. That's why parang he's trying to dismiss it at natatakot. Sabi ko, ay nako, nahan ka na, no?
Kung bago lang at maliit pa, subukan mo na yung gamot. Subukan mo na yung gamot. Baka mag-reverse pa. Okay?
My very unstable, Doc, sorry.
Okay. So kung as I said, kung maliit pa, there's an option na pwedeng gamot na lang muna. Gamot muna. Okay?
Posible, no? Sige, I will give.
Kaya lang, matagalan yung monitor. Okay lang. Kasi ganun din, pag magpapa-opera, usually baka gagamot ka pa rin.
Ganun din.
May radioactive iodine, gagamot ka pa rin after the radioactive iodine. No? Ganun.
Correct.
Okay? So,
sige po. Thank you.
Okay.
Thank you.
You're welcome. Any more questions? If there are no more questions, we call it a day. It's 3.